I've been really fortunate enough to be asked by the ASH organising committee to deliver the diffuse large B-cell lymphoma education session this year. And really, I've kind of looked at how we might use our new insights into the biology of lymphoma and how we may tailor therapeutics appropriately so that we may be able to improve the outcome of patients. I think for many years we've seen that conventional chemotherapy has not added to our outcomes with diffuse large B-cell lymphoma. We've seen that increasing the dose density, increasing the intensity with high-dose chemotherapy and stem cell transplants. We've seen that using higher dose therapies or therapy that's been modified according to pharmacodynamics, etc., has not improved our outcomes. So I think there's a clear need for us to exploit our new understanding of the biology to be able to improve the outcomes of these patients. So we've now got a great insight. We know from transcriptome analysis that we have the ABC and the GCB phenotype of diffuse large B-cell lymphoma. They arise by different oncogenic mechanisms and they appear to have a different clinical outcome, with the ABCs having an inferior outcome. Now, we've looked at using drugs in addition to CHOP chemotherapy that have shown activity as single agents in relapsed and refractory diffuse large B-cell lymphoma to see if we can improve the outcome of any particular molecularly stratified subgroup. So those drugs have included bortezomib, which we've tried in a UK study, and we wait the results of 2 prospective studies looking at the addition of either lenalidomide or ibrutinib to our CHOP chemotherapy, and those results are pending, really. So I think that it's not too far along the horizon that we are going to be stratifying and tailoring our therapies for patients with diffuse large B-cell lymphoma with agents in addition to R-CHOP, but we're not quite there yet. Now, one exception to that, however, is those diffuse large B-cell lymphomas that are double hits or triple hits. So those that have translocations of both MYC and either BCL2 or BCL6. And they represent about 5% of the diffuse large B-cell lymphomas. They typically present with more aggressive features and they have a high risk of CNS disease. And we know for those patients that R-CHOP chemotherapy is inadequate, and we've looked to see if we can improve upon that by using more intensified approaches. Now, those in more intensified approaches, such as Codox-M-IVAC, such as hyper-CVAD, they're all associated with increased toxicity, and the tolerability, perhaps in older patients, is more difficult. We've seen from a number of retrospective series analyses that the infusional regimen dose-adjusted EPOCH is associated with improved complete response rates and progression-free survival advantage, but little to say really there's an overall survival advantage yet. So many of us feel that for these double hit patients, we should be using the dose-adjusted EPOCH regimen with some attention also to CNS prophylaxis. We discussed whether we ought to consolidate people in first remission with high-dose chemotherapy if you're a double hit. The data is not really in favour of that unless you've used conventional R-CHOP chemotherapy. We also talked about the double expressor diffuse large B-cell lymphoma group. So these are patients that have immunohistochemical high expression of BCL2 and MYC protein, but lack a translocation. And we really recognise that that accounts for about 25% of diffuse large B-cell lymphomas and is associated with a poor prognosis. However, there's no standard of care for those patients, and we are urgently in need of new clinical trials to work out how we must best treat these phenotypes. So I think the key message from my talk really is to say, look, diffuse large B-cell lymphoma is not one disease. We need to recognise that there's clear biological and clinical heterogeneity, and we need to action that with our new agents.